first person on our panel is Boyd Mullins, and we're delighted to have him here today. He's the Executive Lead for Workforce Partnerships at Health Education England, and he's working across the entire east of England. Boyd has a wealth of experience across healthcare, education, training, workforce development, and he was instrumental, I think, and we've been working with Boyd a lot on this in the assistant practitioner role, and it's one of the things we're going to be talking about this afternoon. And I'm told his wife and daughter are both registered mental health nurses, so that's well done, Boyd, we've got to say. And I believe that at least one of them's here today. Is that right? You're there. Hello. Welcome. We'd like to invite you to the stage, Boyd, sorry. And you go in the far chair. We've got to do it in order. Yeah, clap. You can clap. And secondly, I'm very, very pleased to have Dr. Ruth May here this afternoon. She's now the Executive Director of Nursing at NHS Improvement. And we've booked Ruth for a long, long time, I think, and we're very delighted to have her here. Ruth was previously at Monitor, the first Nurse Director, and she's come up already, so just go and sit down, Ruth. So applause Ruth. So Ruth's talking later on, and I will introduce her properly. And third panel member is going to be Janet Davies, who you've all met this morning, and hopefully you remember Janet. So we've got 2 microphones to share. So this is really a question and answer session for you. But seeing as I've got the microphone, I'm going to ask the first question if I can, and it's for all the panel. So I'm going to start with the proposed new nursing associate role, or Janet called it something different, I think, this morning. No, it was nursing associate, wasn't it? Is intended to provide greater support for nurses and help bridge the gap between healthcare support workers and nurses. So what do you feel is essential to ensure it can be introduced safely and successfully? And I'll start with Boyd.
Thanks, Andy, and apologies to my daughter who is in the audience somewhere, so that wasn't me. Oh gosh, nurse associate. So I don't think we've quite settled on the title. I think the consultation is looking at, one of the things it's looking at is the actual name. It's likely to be nurse, nursing associate, or associate nurse, so definitely nurse in the title. In some respects, this might sound strange, but I don't think it's anything new. I think the idea of having groups of staff that are not registered professionals, not nurses, working in healthcare has been around, well, ever since I started nursing quite a few years ago. So I think I used to call them nursing auxiliaries back in, 30 years ago. So in some respects, it's nothing new. I think one of the differences with the nurse associate or associate nurse is going to be some of the things that we're going to overlay onto this in terms of national transferability. So I think what we've struggled with nursing assistants, with healthcare support workers, with even assistant and associate practitioners, is that national transferability of that role. You don't quite know whether that person that's been trained in Southend is the same as the person that's been trained in Liverpool. So I think the opportunity with the associate nurse associate is that we'll get some transferability nationally. We'll get some national competencies and some national skills, some national assessment of those people, some proper supervision, and at some point, some form of regulation. And I think all of those things put together, for me, means that it will be a new role and a different role, but it will also have safety attached to it, and it'll have transferability attached to it.
There's, I guess, there's some similarities in our opinions and some differences. First of all, I think the actual role itself and how it supports care, I think we all agree on. I am vehemently opposed to the post being called a nurse because I think it absolutely confuses our clients and our patients. And I think the World Health Organization has got a very clear definition now, and why would we be any different than the rest of the world? However, I think having what the question was about how do we keep it safe, I think that keeps it safe. But I think the really clear thing where we've never done our clients any service or ourselves is the way in which we have not had standardised, organised education and support for support workers to our nursing colleagues. And I think that's the most important thing, that it's rigorous, that it's supportive, but it's supportive to the individuals as well. The nursing auxiliaries did not have standardised training, so I think it's a very different role. I also think that we need to be very careful about calling roles nurses when we're in a period of integration. To me, it feels a bit retrograde. We talked this morning about how we need new roles, how we need interchangeable roles. And in some areas, you might want your band 4 support to actually go across nursing, therapies, even medicine. And actually, I think we're boxing ourselves into a corner by trying to make it just part of the nursing profession. But hey, I think the actual role, how it supports our clients is importantly the thing that we agree on.
Thanks. I just want to say I've really changed my view about this over the last couple of months, and it's actually thanks to some of the challenge that Janet made. So I was absolutely certain in my view they ought to be called nurses. I thought they ought to be definitely accountable and called nurses. I don't now believe that, and that's because I've seen some of these roles in practice. I went to Hampshire hospitals as a result of a challenge by Janet and saw Donna Green and some of her colleagues working with this role already. And indeed, East of England got plenty of examples where this role has been working across all sorts of settings. I now actually believe they should be accountable, but I don't necessarily think they should be called a nurse. So I think it's much more about therapies as well as the nursing support. So I've seen some great therapy associates as well as nursing associates. I do genuinely believe we need to triangulate the outcomes for patients and for staff as well, and I think that's the way we can implement it safely. And then we will have the debate about substitution. You know, are they going to substitute a registered nurse or not? And I have seen in some places where that is happening and it's happening safely, and we all want to make sure that we support that happening if it is only safe, but not at scale. It would be safe in some parts, on some therapy areas, some rehab areas. I think it's possible to do. I won't take any more of the agenda.
Okay, thanks for that. If I can just indulge by being the chair of this, I'll ask one more question. And really it's a follow-up, and I think you've probably answered it, Ruth. But there is something about, in this, and we can talk our trust, we've got massive SIPs to find. We've been challenged with finding £1 million from workforce, whatever that means. And there is a pressure on us to do exactly that, to substitute the nursing and therapy workforce with lower banded staff. And I'm part of that, and I think I've changed my views, and I vacillate on this and what that might mean. But, I suppose the question is, what safeguards do you think we can put in place that it isn't a cheaper version of a registered nurse?
Shall I have a quick go at the moment? So, yeah, I'm dealing with this day in, day out at the moment, given that we've got all the provider sector now, and my gosh, I've never seen the provider sector as a whole in the financial difficulties it's currently in. One of the things that I've been keen to do with all the agency work is, when I started in August in Monitor, and we published in September the work around agency controls for nurses. That's true, it was just for nurses, but by the time the October, November stuff came around, it came out about doctors as well and all other clinicians and non-clinicians. I've been really keen to say it's not just about nurses and nursing. So my argument back to you is, yes, we need to stand up for our profession, and we need to stand and make sure that we are putting our two pence in and making our savings, but actually we've also got a responsibility of making sure it's not just about nursing, it's also about the doctor's contribution So one of the reasons we had to change today's meeting is I've been in this morning with our exec team meeting. I absolutely wanted to be round the table because when we're talking about agency controls and anything else that we're talking about, it's not just about nursing, it's about doctors and other professionals standing up and putting their processes and their input into this. But we do need to recognise too that actually the agency spend has gone absolutely out of control across the country. It is starting to come back within control. Many organisations are doing some great stuff around that, encouraging people to come back onto the bank, encouraging people to come back to work, increasing the bank rates for people in substantive jobs at the moment, but there is more that we can do. And yes, it's our professional responsibility to make sure we've got the safeguards in place. And that's up to us as well. Not just about making sure we've got all the right systems and processes, but you know, in this organisation particularly, you've got a great culture that will allow you to be open in doing that. And I'd argue that make sure that you continue to do that.
I think just to add to that, I guess there is a pragmatic view, and in terms of the money that's coming into the system and the cost of the current workforce. So, you know, there's a pragmatic, I guess, approach that we need to take to the workforce, and in some respects, the workforce is too expensive. I think on top of that, for me, there's something about looking at these new roles and these new types of roles and the benefits that they can bring as well to patient care. So whilst the money is sometimes a driver, that challenge often presents an opportunity. And I think there are lots of examples of support worker roles, assistant, associate practitioner roles that are bringing real benefits to patients in terms of the quality of the care and the quality of the outcomes. So I think, you know, it's probably quite easy to sit back and think about the money side of it. I think what we've also got to do is look at this as a challenge, but as an opportunity to say, well, what are the things that we can bring to the table in terms of improving care and outcomes for patients. I think just to add, the last bit for me is there is also something about a broader workforce element here, that these roles do provide good stepping stones for people to come into healthcare, to come into professional roles. And I think, you know, there's some really good opportunities for us to think through the associate nurse and how that starts to become a stepping point for people to either go into nursing or into other healthcare professions.
I still feel I must keep challenging the associate nurse, and I'm very fascinated by how I believe it probably will come back, because I know it's what the minister wants. We had thousands and thousands of people respond to the RCN consultation, and everybody was very clear they didn't want nurse in the title. So it'll be very interesting to see how it does come back and on who has determined that. I think the medics don't call them associate physicians, so why would we do the same? Interestingly, the consultation went to the medical Royal Colleges, which I think is quite amazing, considering it's about nursing role. I only know because a couple of them rang me up and said, what do you want us to say? Which was helpful. But we know some of the others like the idea of a second-level nurse for many reasons you will all remember. Anyway, can you go? I'll go back to the actual question here. I think it's very sad to hear that we believe the workforce is very expensive. I think we can probably look at the NHS and its whole system and make our own mind up about what we think is expensive. I actually think the clinical workforce is cheap at half the price, given the contribution to the actual activity. I think it's where we're going wrong. I think it's what's happened to the junior doctors. I think that's why they feel like they do. And I think we do need to start valuing and celebrating the contribution that we give. Given that we are where we are living in the real world, and we do have to use our imagination. I think we are incredibly bad at using our imagination. Andy and I were just talking about 12-hour shifts before. I don't think we should be talking about any sort of standard shifts. Put in 12-hour shifts, you get more agency staff, because people who can't do it just can't do it, and they go and work for flexibly. We should be able to, in this day and age, have a system where you can work annualised hours, monthly hours, weekly hours, and in a period of shortage, we should be able to employ people for the hours that they want to work, that works for them. We'll have a committed workforce. We won't have the sickness. We could save tons of money with people not taking time off sick because they're on silly shifts and they're getting tired. Some people might want to work up 12-hour shifts. They're safe to work them, maybe. Then maybe they can. And I just think this whole rigidity that we've got is letting us down and drawing some of that expense. I don't think substitution will save money. I think it will end up, particularly if someone's called a nurse, then the pay claims will be one. They were last time, they will be again. I think we need to stay very clear of that. But actually, if we think we can only afford a certain level, then we need to be honest about the outcomes. We need to be honest about what the NHS is going to provide. I don't want to see a time when we've got a very low skill mix with people trying their best, having something like mid-staffs and those people getting struck off the register, when actually we're expecting too much for that money. Lots of reasons for us to value the staff we've got. Lots of reasons to be, but do it, please, by reducing sickness, by getting people happier at work, rather than cutting their salaries, because we'll just have more sickness and fewer staff.
Thanks, Janet. You don't know the problems you're going to cause me with that now, aren't you? Across the whole trust. It was more fault for asking the question, I suppose, but I think it was a very important question to ask, and I think it was a very telling answer in terms of that. So now you've heard me speak a lot. I'm going to open the questions up for the panel to the audience. Hang on. There's a mic coming.
So, hi, I'm Leona. I'm what's called an assistant practitioner at the moment. Firstly, coming back to the name, it's interesting to hear you argue the point. I think as an assistant practitioner, we're not that bothered about what we're called. In the course that I originally did, there was occupational therapist, training assistants, there was physios. So technically, yes, I agree with Janet. Nurse probably shouldn't be in there, and that's as working in a nursing role myself. However, I think because you're talking about substitution, because you're arguing about the name, what you're doing is creating an us and them situation. Nurses have worked, I'm very aware, I'm in a room full of nurses, and everyone's worked really hard to get that qualification. I'm working on a pathway to get there myself, but I think people that don't understand the role already, when as soon as you talk about substitution, people that have worked hard to become a nurse get very defensive. It's about taking their jobs and things like that. And what we want to do is work alongside, have our own pathway and to forge our own way to what we're doing, really. So, I'm sure everybody understands. I'm not that's not what I meant, but yeah.
I think it's a really interesting and important point. I think when I first started doing the work around, it was the assistant and the associate practitioners in Essex about 10 years ago. I think our original vision for that was that the purpose of having assistant and associate practitioners was very much about it being multi-professional. It wasn't aligned to a particular professional group. It gave people the option to experience nursing, occupational therapy, physiotherapy experiences, but also it gave people an opportunity then to step into one of those professions if that's what they decided to do. And I think the other key thing for us at the time was about actually what the patients and clients were saying is they weren't, in some respects, too worried whether it was a nurse or a physio, but what they were interested in was that sort of whole system care, the fact that someone could offer some traditional nursing inputs, some traditional occupational therapy and traditional physiotherapy inputs. So in some respects, and I'm slightly shackled by what I can say working for HE and what I can't say, I think it is a shame that we've ended up with a consultation which is about taking us back to something that we are aligning to nursing, because I think some of the original aspirations of those assistant associate practitioners was much more in tune with, I think, where the 5-year forward is taking us, which is about whole system care, not specifics to professional groups.
Just to say that, how do you see it going forward? I've been qualified for 5 years, and they've talked about regulation from the beginning. The RCN have got a database that you can register yourself with, but there isn't any formal recognition or requirement to do it as yet. So it feels like we're in the same sort of situation as 5 years ago. Nothing seems to have really moved forward, and we're still asking the same questions, really.
I'll probably put some comment, then probably Janet will want to say a bit more. I think your first bit, though, was around the role that you play in an added benefit to the whole team. And I think that's what I was saying really about the whole workforce, is that you need to be thinking of it as a whole team, not just about registered and unregistered workforce, which is what we keep counting at the moment. On the issue around accountability and registration, I am hoping the NMC will register these professionals. I absolutely would like to see that. As to whether they will or not, I don't know. I don't know the outcome yet of the consultation coming from Health Education England. I do know that they're going to be putting their board paper at some time this month when we'll see it. That'll be in the public domain, and I'll see that at the same time as you. But I am hoping that they will recommend, or we will recommend as a whole, some accountability through to the NMC.
Yeah, and I think this is where there's absolute consensus. I mean, the RCN have been calling for regulation of healthcare support workers for years now. I think it's the only way to keep the public safe. It's the only way to keep ourselves safe. So I think we're all on the same page. We're all lobbying the NMC. We're hoping for a Section 60, which is the way of doing it, and getting a new register opened. That way, I think it can be more flexible. So that's the way we would expect them to do. We all talk to the Chief Executive of NMC at regular intervals, trying to persuade. But just to reassure you about where the RCN, well, you know the RCN are already in favour of these roles, but actually giving options for people to progress who want to. But for those people who don't want to, and I think this is really important, it is a very valuable role in its own right, and it's all right to stay in those roles. It's absolutely a very, very valuable role for the care of our clients. So we don't all have to go and progress to be a registered nurse, but for those who want to, it should be easier than it is now.
This is an education question. I just want to know what we can do to improve the CPD opportunities for our staff, particularly in these sort of challenging financial times.
Now, Anthea's been chaperoning me all day, and she said she wouldn't ask me that question. But she said there's lots of people in the audience that probably would be interested. So, oh gosh, I think CPD in the east of England is a very tricky subject at the moment for those that are in the audience and waiting for the traditional money that fills into the system for CPD. We're quite late doing that this year, and unfortunately it tracks all the way back to something Janet talked about earlier, which was the comprehensive spending review. The fact of the matter is there is less money in the system for CPD than there has been in the past. So that's not something that we can skirt around. It's there. It's something that HEE is having to deal with. That said, I think what we've done in the east of England, we were looking at some comparisons across the country. The CPD spend that we have in the east of England still far outstrips some of the other LEPBs across the country. Sometimes it's really hard to compare, but so that doesn't sound like a great bit of news, but the amount of spend that we're putting into CPD is still relatively quite high. I think the other thing for me is about us. One of the things we've got to do is look much more focused about what we're spending that CPD money on, the quality of those programs, and the outcomes that you're looking for as practitioners in terms of that CPD. The work that we've done with trusts recently shows us that people are still spending CPD on things that are quite outdated. And I guess the focus for us needs to be about thinking through how do we use a smaller pot of money, but making sure that it's targeted on the right things for organisations.
To say on this, I guess, not unsurprisingly. In yesterday's Nursing Times, I think it was about Professor Fiona Nolan's being appointed locally as the first chair of the Florence Nightingale Foundation in clinical mental health nursing practice and research. So that's fantastic that there is now that for the mental health nursing community, and of course it's local with Essex. I guess what I was going to say as well is that there's lots of foundations, just like the Florence Nightingale Foundation that's there. Make sure you're accessing that. I've just finished my leadership scholarship there. Really superb, excellent. They keep you on your toes. You do have to work for it, but my God, it's a good resource for people to apply for. I'm going to talk a bit more in my speech. I don't want to say too much about it, but I'm keen for people, if they want to shadow any of us in NHSI, then you're welcome to do so. So some of that experiential learning can be there with only your travel costs and time. It doesn't have to take a whole load of fees to do so. And indeed, if you want to be part of any of our work around mental health staffing, community staffing, or whatever, anything else that we're doing, just email me. You'll have my email on my presentation later, and you can be part of that. Again, some of that experiential learning. It doesn't all require investment in terms of finance.
Yeah, I guess the first thing is about enabling people to have that time for reflection and that time to learn. I think revalidation really helps with that. But every organisation does need to, and I know in times of difficulty and austerity like this, yet again, it's another difficulty in releasing people. But I do think giving people that time, even if it's short periods of time to develop, pays back in dividends, both in terms of improved practice and improved, I guess, enthusiasm. Because we all know, after today, you'll probably all go back feeling quite refreshed, even though you've, been learning. So I think more of this, more of opportunities, but also finding your own opportunities. And I mentioned that this morning, really. It's not always about waiting for things that your trust might give you or you might see in the NHS. Get out of the NHS, see some of the other things that are going on. There's so many free programmes around leadership development, lots of things that you can get involved in. And also, money is tight. I mean, you couldn't make it up, could you? I have to say this, but what government can possibly think that when you're short of nurses and the health service is struggling to take the money out of education is quite amazing. If you went to a top FTSE company, and look where they invest their money when they've got problems, it's actually in the staff education. So, interesting dilemma. But there's lots of other funding. So we have got the Florence Nightingale Foundation. They do the most amazing bursaries and scholarships. The Cavell Nurses Trust, the RCN, we have loads of bursaries available, even for people who are doing, a postgraduate degree or a PhD. There are lots of other organisations, that's just 3, but all around the country. The Association of Needle Makers, who's heard of them? They give loads of money, for nursing bursaries. There's lots of them around. So don't worry about Health Education England's money. They haven't got any, bless them. But you look, and you will find tons of it. So just get up and have a look for it. You'll find the funding, you just need the time.
Hi, I'm Brian Jackson. About 18 months ago, I went to a conference, East of England. I'm not sure, I think it's working. East of England conference. There was a Lord, and I've forgotten his name, who was at this particular conference. And they were talking about students, sometimes up to 7, 8, 9 on a ward with the senior students mentoring other students. I'd be honest, I wasn't a fan, and particularly if it came to mental health, and I wondered, had this any legs, and has it gone any further?
I don't know who the Lord was, but probably Lord Willis. Lord Willis. So there's some student-led wards being held around the country. I think the best place they've got that is James Padgett and Norfolk and Norwich, but James Padgett has probably taken it really well. I've been up to that ward. It's a pretty inspiring ward, and actually it's now about 6 or 7 wards in the trust, where, if this will age me, I guess, but students are in charge of the ward, but with their supervised registered nurses there with them and doing supervisors. Now, some of you are old enough to remember, I know one person in this room is old enough to remember, how we used to have, my nurse tutor was Miss Fleurs, when we used to be in charge of a ward as a third-year student. We used to have our tutors, and it's very much in the same vein as that, but it feels an awful lot safer because these are people that are there supervising your practice. After you've done part of your shift, you will then go and think about the anatomy, the physiology, and start writing up your reflective practice, and then present it as part of a team. Brilliant. If you really got half a day or a day, it's worth going up and see James Padgett. I know it's not mental health, and it is award-based, and you could look at it in a community team, but actually the philosophy is really interesting and really exciting. And what the registered nurses are saying is that when they've got a queue of people now saying, we want these newly registered nurses to come and work on our wards because they're ready. They're ready to be in charge, they're ready to do their shift, their preceptorship is a lot less time. It's really working well. But have a look for yourself and see what you think. Well worth a visit.
Just to add to that, I mean, I wasn't a fan of it when I first heard it, despite the fact that I grew up in that world of being a third-year student and being in charge of a ward. But I think, like Ruth said, there's some really good outcomes coming from that work, and we are looking at spreading that to other organisations, and we are starting to look at mental health and community teams as opportunities. I think apart from those benefits, the other thing we've really noticed with those is the sense that the students do get a very different experience. At the moment, the experience of students is very much dependent on their one mentor within a clinical environment. And whilst that can work really, really well, it can also work really badly. And the idea of, so at the moment there's various abbreviations. Sometimes they call it CLIP model, sometimes it's called PEBBLE, but it's very much about students being in charge of that ward with supervisors supporting them. The experience of those students being supervised by other students and having a range of coaches and mentors when they're in a clinical environment is having a really positive impact on the student experience and what they get from their training.
I think we're going to have to look differently at mentorship anyway, because we're going to have a bit of a dilemma, I think, because we're going to have an unknown number of students, and allegedly, who are coming through the undergraduate programmes because they've taken the cap off that. Plus, we've got the nurse associate training that's coming in. Plus, we've got higher level apprenticeships. That is a very crowded space for a limited number of clinical areas. So we are going to have to think differently about how we have very, very good quality mentorship. Interestingly, a couple of weeks ago, the RCN, Council of Deans and the NMC introduced a joint piece of work that we're doing on new mentorship models. I think we've got slightly different thoughts. When putting it all together, we could probably have something quite powerful. We do have to think totally in a different way. I was very taken this morning by meeting a student buddy who's a service user. That is a fantastic model to also support our students. We just have to think differently about what will give the best support to nurses, I think.
What role do you see community trusts helping and support when we hit the black alert, when we have the winter pressures? And how do you think community trusts could do, what could they do to assist in that and alleviate the pressure? How do you see that? Because obviously, I know we're not supposed to say winter pressures anymore, but we know it's going to happen, and we know that there's pressures all the year, but particularly in that time of year.
Ruth, you can start. I think.
Thank you. Absolutely. You know, we've moved on from winter being just for winter, but it does happen all year round. I think the people are putting a lot of store at the moment by this SDP process. I think we've got also to think about Pauline Phillip, Chief Executive Luton and Dunstable, who's a nurse by background. She has managed to lead an organisation that many will know that Luton Dunstable were definitely nowhere near the 98% target, even when it was 98. She's now leading the piece of work nationally around A&E and contribution of that. Community services are absolutely on her agenda around that. I don't know if any of you have been to Luton and Dunstable. They've got a massive community service at the front door, not just GP, but GP and community service at the front door. So you have to go in there first, unless you're on 999 and stuff, before you even enter an A&E. Really, really powerful model about how community services can step up and have a very different approach. Well worth a visit. Get involved with Pauline. If you want me to put you involved in that, through into that, no problem at all. Definitely a role for community services. We'll need to get over the A&E consultant issues, because there'll be a few of those type of things we'll need to manage through. But I think it's definitely worth a challenge, particularly now coming up to the next autumn.
Yeah, I mean, I guess it depends on where the problem is. So if it's at the front door with people coming in who don't need to be in, then I think there needs to be investment in community, perhaps to stop them getting to the front door. If they've got to the front door, exactly what Ruth is talking about, but also is that what really the problem is, or is it the fact that people can't be admitted because there are people still in hospital who perhaps could leave hospital? And that takes a much more sustained, longer-term investment and ways of doing things, and it involves social care as well as healthcare. So maybe some of the models that we're seeing through the vanguards, some of the integrated models, they may make a difference, but I think the more we don't separate social care and healthcare, particularly with people with complex needs, then we might have a chance of getting people in the appropriate place for their needs.
Time for one more, Anne. Quick question, just a quick question.
I've never done karaoke before, and I now know the reason why. Okay, I work in community children's services, and my question to the panel is, how do you think we can maintain the stability in the nursing workforce, bearing in mind we're faced with multiple commissioners and multiple procurement processes that have been occurring, and we've experienced within SEPT in particular because of Essex taking forward a number of different procurement processes for public health and children's services.
Yeah, I mean, I think, first of all, the difference in commissioning is causing difficulties now as we speak, isn't it? Particularly in terms of local authorities commissioning. Health visiting school nursing is the two that we're looking at the moment. There is a couple of things we, first of all, need to do, I think, is obviously they're even more difficulty than health in terms of their funding. So probably the arguments they're having are the same as we've just been hearing about before. But there is something about how we ensure that everybody understands the role, and how do we justify what those roles are, what the outcomes. So the same thing I talked about this morning really is about having that evidence about outcomes, about ensuring that people understand what it is that they're commissioning. So that's the roles of the commissioners. The other thing, though, is around how do we keep people within the system? So how do we keep nurses engaged enough so that they stay in nursing, no matter where they work? And that is all to do with those factors of valuing nurses, having flexibility, having different rewards other than salary. So all the things we've already talked about across the whole of the system. It becomes very disjointed, I think, with all these different providers. And I certainly haven't got the answer. But it's a really good point to raise, because I think we've got a bit more problems to come before we start getting the solutions.
I got some just very quick points, which is Michelle McLaughlin, the Director of Nursing from Birmingham Children's Hospital, is leading a piece of work for me on children's staffing. So it'd be really good at some point to link you in with that about staffing. But in terms of procurement, I think it's a travesty about where we are with health visiting at the moment. I remember in my old job in East of England, we were counting health visitors, recruiting health visitors, training health visitors. Now all of a sudden we're into the debate about, with local authorities, about, in some areas anyway, not necessarily here, but in some areas they're decommissioning them. And I think I have a role to act as a voice of that. But I do believe that the new NHSI no longer monitor. We've moved away from everything being in competition. Everything has to go out to tender, so much as being much more about collaboration. So I'm hoping some of those tender stuff will become a lot less. I'm hoping.
And I think just not to sort of go back on the commissioning side of things, I guess the other thing for me is just picking up on Janet's point is about the valuing of the staff that we have got. So, it's been mentioned a few times today in the sense of what we need to do is we need to work really hard to make sure that we retain and respect the people that we've got in the workforce at the moment. So I think everything that you can do as an organisation, to think about the health and well-being of your staff, and certainly looking at one of the stands out there, it's certainly something that SEPT is sort of really on at the moment. So I think there's a big challenge there, but certainly retaining the people that you've got and looking after the people that you got is really important.
Okay, can I thank you all very much for that, and I shall appreciate it. Thank you.